Okay. Hello, everyone. Welcome, and thank you for joining us on the South Sudanese Women Intellectuals Forum. My name is Dr. Anne Lomole. I am a pediatrician and an infectious disease consultant, and I will be your moderator for this session. Today, we will be discussing the importance of screening and surveillance in the prevention, treatment, and control of diseases. The primary purpose of screening for diseases is to identify early signs and symptoms of a disease or a health problem, and to implement early treatment or program intervention, and also to reduce the emergence of disease or death from that particular illness. With the costs of healthcare, the impending shortages in human resources, and the increased prevalence of chronic conditions, fewer resources are going to be available in the future for treatment. Screening and surveillance as measures to promote population health are therefore becoming increasingly important. Screening and surveillance give opportunities for cost-effective measures of controlling disease, not only in the individual, but also in the population, and may reduce the burden on the healthcare sector due to early intervention to prevent progression of diseases or to control outbreaks. Now, disease outbreaks and other emergencies constitute a serious threat to public health security worldwide. And we have seen this with the COVID-19 pandemic. A delayed and incomplete indicator and event-based reporting therefore limits health managers and public health managers' ability to initiate timely event investigation and responses. And these reporting delays further constrain the rapid event containment that would be necessary to ensure that there's no spread of disease, and thereby leading to extensive international disease spread and excess morbidity and mortality. During humanitarian emergencies, as is mostly the case in our country, South Sudan, detecting and responding swiftly to epidemics is key in order to reduce unnecessary illness and death. It is therefore important to discuss some of the diseases targeted for screening, discuss who should be screened and when, and why it's important to screen for these diseases. It's also important to understand the strategies behind disease surveillance and collection of data for specific illnesses that are associated with significant morbidity and mortality, and also emphasize the need for surveillance for some of these diseases. We will also discuss some of the challenges that are associated with collecting this data, with screening, and possibly also identify some solutions. This is especially important in our country that is currently coming out of a post-conflict state and is in the process of building up their healthcare sector. We would like to thank our panelists today for joining us for this important discussion. And we are currently streaming live on Facebook and YouTube. Please do not hesitate to answer or to ask any questions on our wall, and we will try and answer as many as we can. We also want to thank our audience for joining us for this discussion, and feel free to share the discussion on any of your social media platforms. We would also like to thank the UN Women for their support, and Aisha, who's behind the scenes with technical support. So I will go straight into introducing our panelists today. So today we are joined by a number of very special panelists, and I just want to thank them for taking the time to be here today. We'll start with Dr. Jane Abucha. Dr. Jane Abucha is a professor of nursing and a clinical and classroom instructor for the Carrington College of Nursing Associate Degree Program. She earned a degree in 1988 as a nurse practitioner, so she has a wealth of experience, and she also earned a degree in medicine. In the United States, where she moved, she earned a bachelor's degree in nursing science and a master's degree of science and nursing with a specialty in acute care as a nurse practitioner from the Grand Canyon University, and she currently holds a doctorate of nursing practice. Thank you so much for joining us, Dr. Jane. Next, I would like to introduce Dr. Ayak Deng. She's currently not on the screen, but hopefully she will join us. She's not in a place with very secure internet connection. She is an obstetrician and gynecologist at Mary Health Hospital in Wau, South Sudan, and she received her Bachelor of Medicine and Surgery from the University of Upper Nile and completed her Master of Medicine in Obstetrics and Gynecology from the University of Muhimbili in Dar es Salaam, Tanzania. So when she comes on screen, then she will be able to say hi to the audience. Next, we'd like to introduce Dr. Sandra Banks, who is a graduate of the University of Juba School of Medicine. She served as a medical officer at the Juba Teaching Hospital and as an assistant lecturer in surgery at the University of Juba College of Medicine from 2010 to 2018. Dr. Sandra was also part of the National South Sudan Cholera Outbreak Response in 2017 and played a part in EVD preparedness and readiness with the South Sudan Red Cross, supporting infection prevention and control, risk communication, and community engagement. So she's going to talk mostly about the public health aspects and epidemics and the control, things that people would like to hear about, especially in this COVID-19 era. She's also a former Miss South Sudan and has hosted education sessions on radio with the aim of increasing community awareness on endemic diseases and means of infectious disease prevention, and is currently supporting the national COVID-19 response. I would like to introduce Dr. Victoria. Dr. Victoria Majur is a director of the HIV/AIDS and STI department at the National Ministry of Health. She previously worked in Australia as a general practitioner for a few years before coming back to the country to give back to the nation in 2012. And she is a member of the Australia Society for HIV Medicine and a member of the Technical Advisory Committee for the African Society for Care of Children Living with HIV. She is also a former member of the Board of Directors of the South Sudan Broadcasting Corporation and a former presenter in SSBC on a health program called Ask the Doctor. She is a member of the South Sudan General Medical Council and a strong vocal advocate of women and girls' rights. She was also a finalist of the Irene Krestav Award, which is an Australian award that is given to refugee women in absentia. Benna Mark, who is a psychologist with specialization in counseling and health psychology, and is currently a psychology PhD student in the area of trauma and community counseling, and the current head of Department of Psychology and full-time lecturer at the University of Juba. Unfortunately, she will be able join us maybe. Oh, thank you. We'll go straight into our discussion. Sorry, I dropped off a bit there. There's a bit of an unstable internet connection. Sorry, we have a bit of Dr. Ayak. Okay, so if we can all mute, we will go straight into our discussion because there seems to be an issue with the internet connection. I hope you can all hear me. Dr. Ayak, if you could please mute. Okay, I will go straight into the questions, and I would like to direct the first question to Dr. Sandra. Dr. Sandra, are you with us? Okay, I can see Dr. Sandra. Dr. Sandra is getting, okay. Dr. Sandra, the first question will go to you. I hope you can hear me despite your video being off. So if you could please define for us what screening and surveillance is and what the types of surveillance are and why this is important from a public health perspective and some of the diseases that are targeted for surveillance and why. Dr. Sandra. Dr. Sandra, are you still with us?
Dr. Ann, I think I'm having a bit of issue with my internet. I was not able to hear you clearly. If you can hear me clearly, please confirm. And if you could kindly repeat what you said. I had to switch from my phone to my laptop So if you can hear me well, please confirm and please repeat your statement. Thank you.
Great, thank you, Dr. Sandra. So I was asking you if you could please define for us what screening and surveillance are, and what are the types of surveillance, and why it's important to do surveillance from a public health perspective, and maybe indicate for us what are some of the diseases that are targeted for surveillance and why.
Okay, I think I got the first part of your question. I missed this the last sentence you said, but just going on to surveillance, onto what surveillance is, and specifically we're focusing here, of course, on public health surveillance. So just to break down the word, surveillance comes from two words: "sur," which means above, and "velar," which means to watch. So it's like you're watching on something from above. So in our context of public health surveillance, we define it as the ongoing systematic collection, analysis, and interpretation.
Sorry, we dropped Dr. Sandra there. I think when she's back, she will continue with that definition. Dr. Jane, since your internet seems a bit more stable, you and Dr. Victoria will concentrate on you for now. So we'll start with Dr. Victoria. Sorry, Dr. Sandra? Maybe you can continue since you're, okay, she's gone again. Sorry, this is a problem with internet connection currently in South Sudan. So we'll continue with Dr. Sandra is back. Dr. Sandra? Okay, continue, please. We seem to be losing you.
I will, okay, sorry. I will try to keep it short. I'm going to turn off my camera so I can make sure that I maintain the bundles for the audio. So it was just on what surveillance is, which is it's the ongoing systematic collection, analysis, and interpretation of health-related data, which is essential to the planning, implementation, and evaluation of public health practice. So, of course, in order for you to plan any response or any intervention measure, you need to analyze and assess the situation and the condition on the ground. So this is why we have to collect the information, we have to analyze that information, we have to report on it, and we have to, of course, give the feedback to the policymakers in order for us to have tailored intervention mechanisms. So basically, public health surveillance is used to undertake and to inform disease prevention and control measures, and primarily the main objective of it is to reduce morbidity and mortality and to improve health in general. So and in most cases, surveillance is really to serve as an early warning system. If we have even though say for example cholera, if we know that we have if there's a cholera outbreak happening in an area and we don't have a surveillance system that will inform us that there is an outbreak happening in that area, we will not be able to respond. We will not be able to mobilize the different intervention efforts to control that outbreak. So primarily, it's an early warning sign to identify impending epidemics and other public health emergencies. And we also use it to monitor the epidemiology of a condition and to set priorities. And it also helps us to guide policies and strategies. Say, for example, the malaria control program, for instance, or even in HIV interventions and tuberculosis drug administration. So surveillance is key in each and every aspect of any health activity in all the different sectors of the Ministry of Health. Also, it documents the impact of an intervention or progress. So initially, where we have an issue, we detect it, we analyze it, we tailor our or we plan the different response efforts on how to tackle that public health issue. And then it also helps to document the impact of that intervention. So it helps to give us feedback whether or not the intervention that we implemented has succeeded or we may need to change it. So these are all the different aspects of surveillance. So making decisions, collecting and transmitting the information, analyzing that data, and feeding back to the system for intervention, setting priorities, guiding public health policies and strategies. So when we're looking at the different types of surveillance, we have many different categorization of defining or grouping surveillance. But broadly, we have the healthcare facility-based surveillance and the community-based surveillance. But I am one of those who like to describe surveillance as passive and active. So we have passive surveillance, which is the routine reporting of health information, which is what we see every day in the different healthcare facilities across the different counties and the BOMAs and the different states in South Sudan. It's the routine reporting of health.
Okay, we've lost Dr. Sandra for a bit there. I'm sure she'll come back. I was liking her definition of surveillance as active and passive, because I personally also like that definition. So as she still finds a way to get back on the screen, we'll go to Dr. Victoria. Maybe Dr. Victoria, you can help us. Dr. Sandra has talked a bit about disease surveillance, and I know there is ongoing surveillance in South Sudan. So what are the specific infectious diseases that have been targeted for screening and surveillance by the Ministry of Health in South Sudan, and why are those specific diseases targeted for screening and surveillance?
Thank you, Dr. Anne, for the opportunity. South Sudan currently have 53 priority diseases under surveillance, and the system they're using is called EWARS, EWARS, which means Early Alerts Response System surveillance. And out of these 53 diseases, which has a lot of, which I will not mention all, there are 17 that the ministry is targeting. And out of these, we have priority, we have prioritized malaria, acute watery diarrhea, acute bloody diarrhea, Ebola virus disease, COVID-19, measles, HIV, TB among them. And reason being, the few that I've mentioned are being prioritized by the Ministry of Health because of the morbidity and mortality. Actually, malaria, acute watery diarrhea, acute bloody diarrhea, and acute respiratory infection were the leading cause of mortality and morbidity in the last few months in 2020. And it has accounted for almost 50% of morbidities and 30% of mortality. And that's why that's the reason Ministry of Health is prioritizing these ones. The Ministry of Health has an IDSR system, Integrated Disease Surveillance Response System. And in the 10 states and 3 administrative areas, we have IDSR officers. And in the 80 counties, we also have IDSR officers using the EWAS system and giving alerts on daily basis. And these alerts are sent to the Emergency Operating Center, which is based in the Public Health Laboratory. And we have a database where all these alerts are reported and are used for policy, for informing policy and for programming. So basically, these are a few of the diseases that are under surveillance. In terms of screening, we have screening at health facility. TB is one of the diseases screened, HIV, and we have screening at antenatal. Antenatal clinic through PMTCT, it's a mandatory to screen all pregnant women for HIV, making sure that when they're positive, they are put on lifelong ARVs, something called option B+, to safeguard that babies are born negative, babies of positive women are born negative. We also screen pregnant women for syphilis. It's a mandatory screening so that they get treatment at early stage. We are supposed to screen hepatitis B and C at antenatal, but because of resources, we're not able to do that due to the lack of testing kits and the lack of support to the hepatitis program, which we'll touch on later on in the other questions that I will tackle later.
Thank
also,
you so
in HIV, we screen for TB. Every HIV positive client is screened for TB and vice versa. And that lies in the TB HIV collaborative activities.
Thank you so much, Dr. Victoria, for that brief overview of what is happening in our country in terms of screening and surveillance. You've talked a little bit about some of the screening tests that are done in pregnancy, and we have Dr. Ayak on the screen. She's an obstetrician and gynecologist, and maybe she can expound a bit further about some of the diseases or conditions that are screened for in pregnancy, and when it's done and why it's important to screen for these diseases. And specifically as a clinician, what steps are taken when they identify issues, and whether some of this screening for women can be done before they conceive, and why? Dr. Ayak, I hope you have gotten the question. Please go ahead. Dr. Ayak, have you been able to hear the question that I have? Have you had me? Am I clear, Dr. Ayak? Dr. Ayak, you're currently muted. If you can unmute yourself, please. Dr. Ayak? Okay, that's fine. Okay, we'll leave Dr. Ayak for now as she sorts out her audio, and we'll go back to Dr. Sandra. Dr. Sandra, you were discussing about some of the importance from a public health perspective of surveillance. And Dr. Victoria has talked a bit about the South Sudan disease surveillance system. What are those sources of information for this disease surveillance system, and what are the challenges that have been experienced in collecting and collating this information from a South Sudan context? Dr. Sandra. Dr. Sandra? Okay, we seem to be having...
Hi.
Okay, great. Yeah.
Hi, Dr. Anne. Sorry, I missed one or two of your sentences, but I heard the beginning where you were mentioning or talking about the Integrated Disease Surveillance Response, which is the IDSR, which is the main surveillance or disease surveillance reporting platform that we're using in South Sudan. So the IDSR was initially set up by the regional WHO committee, AFRO, in 1998, and South Sudan adopted it in 2006. So by 2013, we had all 80 counties and 10 states implementing the IDSR, and currently South Sudan has moved into IDSR 3. As Dr. Victoria said, we have about over 50 diseases that are reported through the IDSR, and of course, this reporting comes from all the way down to the BOMA level. So you have the different state and county surveillance officers and other IDSR officers detecting and sharing reports of these health events, as we say it. So of course, the IDSR, maybe it's because initially it's like a paper-based and then it's converted to digital-based. It may take some time if we're talking about emergency situations. Say, for example, we have an Ebola alert somewhere. So we also have the EWARS, which is the Early Warning and Response system, or the Early Warning and Response Network. So with the EWARS, we call it like EWARS in a box because it's more or less the same reporting system, but we can transmit information to Juba at the EOC, at the Emergency Preparedness and Response Directorate in the Ministry of Health in less than 48 hours. So all you need is a mobile phone. You have solar batteries to charge your devices, and there are personnel at the different BOMA and BOMA and PAYAM levels who are trained on how to enter information. Of course, under the BOMA Health Initiative, we also have the different healthcare workers also at healthcare facilities, the different levels of PHCs, PHCCs, and PHCUs who have all been orientated on the EWARS and the IDSR, and who can also report these events and make sure that event is reported back to the Command and Control Center, which is the Public Health Emergency Operations Center in Juba, for a triggered and a rapid and early triggered response. So these systems are in place and are functional. And every week there's a reporting for the timeliness, the effectivity, the completeness of these reports that is being done at the Ministry of Health. So maybe if you can just repeat the last sentence you said, so I can respond to it before I go to the challenges that we are facing with regards to getting reports from the different levels.
Okay, so I think you answered. I was asking what are the sources of information, and I think you've given us an overview of that. So maybe before you go off screen, you can tell us what the challenges in collecting this information is in the South Sudan context, and how can the early warning system that you have talked about be improved in South Sudan? If you can give us a bit of your thoughts on that.
Okay, thank you, Dr. Anne. So just to add on more on the sources of information, of course, in addition to the human resources that have been capacitated with the ability to do active case searching and to detect and to report and to enter the data, etc. We also have healthcare facility line lists and books, of course, which record the number of people coming to the healthcare facilities, the number of deaths, like the birth and death registries. We have different line lists for malaria, for example, for acute respiratory infections, for diarrheal diseases. So all these different manually filled, spreadsheets that we have at the different healthcare facilities are actually used to get information. Of course, in addition to laboratory tests and laboratory test results as well. So if we suspect, for example, measles outbreak somewhere, we always have these samples collected and sent to the public health laboratory here at the central level. And of course, the laboratory also holds extensive database on a number of tests conducted, the locations of these samples and the results, etc., etc. So we have different sources of getting information and then collating it, entering it into the IDSR, collating it, and then analyzing that information to help tailor the different or to give us more insight into the different needs that we have on the ground. So some of the challenges we have, of course, I think one of the main challenges is under-reporting. We have maybe several conditions which may be mildly symptomatic or asymptomatic, as we can see now with COVID-19. Almost 75% of people have no symptoms. So automatically, if you don't have symptoms, you don't know that you're sick, so you won't go to a healthcare facility, and thus it's not reported and it's missed. So, and there are many reasons for the under-reporting. It's either that you don't have symptoms, or you don't know that you're sick, or you don't have access to healthcare facility. You don't have a healthcare facility in your setting, a PHCC or PHCU. So if you don't have access to health services, that condition will not be able to be detected. And also the health-seeking behavior. We have seen over the last few years that a lot of community members are now more eager to seek health care in healthcare facilities, but in many instances, not most, in many instances, we also see that people don't have a positive health-seeking behavior, and thus we continue to miss some cases. In other areas, we have issues of logistics and communication challenges. EWARS, for example, you need a mobile data or a mobile network connection. So even though it's remote, it can transmit information back to Juba in 24 hours. If you don't have network coverage of some sort in that area, you will not be able to transmit the information, and you will need a healthcare worker on a bicycle to go to the county health department to send that information, which could take days. So logistics and communication challenges. We also have in addition to healthcare facilities, of course, comes with it the availability of healthcare workers and the availability of healthcare workers who have been trained on how to detect these diseases. We also have the community-based surveillance. Community healthcare workers in many locations, in many counties and bomas, these initiatives are in place. But for quite some time, it was a challenge. But we hope that now we're moving to IDSR2, and I think the country has learned a lot from 2 years of practicing of Ebola virus disease preparation, preparedness and readiness. So there has been a lot of capacity building for EVD, for cholera, and for infectious diseases just in general. So I believe that we are now more prepared, and we are in a better position to detect diseases and other public health events more rapidly and get a quicker response with regards to intervention measures and control measures as well. I think maybe this is from my side for now, and back to you.
Great. Thank you so much, Dr. Sandra. I think it's important that you have mentioned to us that our country is learning its lessons when it comes to surveillance, and we're trying as much as possible to use modern technology to ensure that some of this data is received centrally and we're able to intervene if possible. I know we struggle a lot with issues with logistics and security, but in time, I think we should be able to get there, and we have to be as innovative as possible when it comes to solutions for collection of data related to surveillance for diseases. Now, before we go to Dr. Jane, because we currently have Dr. Ayak on the screen, she's joining us from WOW. We hope she can be able to just get a little word in. Dr. Ayak, can you hear me? I'd like you to please answer my first questions about some of the diseases that are screened for in pregnancy and why it's important to screen for this.
Yes, I can hear.
Dr. Ayak, yes. So what are the major diseases that are screened for in pregnancy? When is screening done, and why is it important to screen for these diseases? And what steps are taken when issues are identified?
Good afternoon.
Go ahead, Dr. Ayak.
Okay, thank you for the opportunity. Yeah, thank you for the opportunity. This is so it is a physiology, but due to the physiological change during pregnancy, there are some complications that may arise. So every pregnant woman should have an access to antenatal care. During antenatal care, we screen for diseases. The most important disease we screen when the woman comes to the antenatal care, we have chronic illnesses, hypertension, diabetics, heart disease. Woman may have them before she's pregnant, or there's also hypertension that is induced by pregnancy, or diabetics induced by pregnancy, called gestational diabetics. And also we screen for infection, HIV, we screen for hepatitis, we screen for syphilis, especially we are in malaria endemic area, we screen for malaria, anemia, urinary tract infection. So these are the diseases we screen for. Why we screen for this disease? Because outcome to the mother, baby, or both of them. So the early we screen, the early we do intervention, the less complication we get. For example, in case of chronic illnesses, if we don't detect those diseases and then we don't manage and control them, it could be dangerous to the mother and to the unborn baby. For the case of infectious diseases, if they are not detected or treated, there is a risk of transmission of the disease from the mother to the unborn baby. So we don't want also to get a sick baby. So that's why we screen, to protect the child from getting those diseases.
Thank you so much.
I hope I answered the question.
Yes, you have. Thank you for that brief overview of why we screen for these diseases in pregnancy, and it's mostly targeted towards both the mother and the baby. We protect both for that with that kind of screening. So since we still have you on the screen, I'll go to your second question. So during pregnancy, the focus is not only on the mother, the unborn baby is also screened. What does this entail? Like, what kind of conditions are screened for? And why is this important? And are these services for screening the unborn baby available in South Sudan? Which ones are available?
So for the baby, simple screening we do here in our setting, we do ultrasound to the mother. So every pregnant woman at least should get 3 ultrasound during ultrasound checkup during pregnancy, like in the early pregnancy, especially if the mother forget her last menstrual period date, so we can date the pregnancy, and we know exactly when this mother will give birth. So we do another ultrasound and we see if the baby has any congenital malformation. If the baby wants any congenital to us, like the presentation, if the baby coming normal presentation, so they will help us as a doctor to plan the mode of delivery. If this woman will go to normal delivery or she will need a cesarean section, this can tell us. So for more than this, unless there is indication, these are the tests we do here in our setting. Is this test available? Yeah, the tests are available. All the screening tests are mentioned in available available. Only there is a unequal distribution of the surfaces. So we can get the surface more in the city, in the center. The more rural you go, the women, they don't get the surfaces. So there is
Okay. Sorry, Dr. Ayak, you seem to be breaking a bit there, and we understand because
lack of the surfaces in the women who are in the rural area.
Yes.
Yeah.
Thank you, Dr. Ayak. You seem to be breaking a bit, but I think we've gotten the gist of what you have talked about, that one of the main screening that's available for the unborn baby is the ultrasound, which is a very simple screen that is able to track the growth of the baby and is able to pick out some abnormalities, including even issues with the organs and their development, and to see if the baby is actually growing in the kind of tangent that we would like. Of course, there are other more invasive screening tests that are done in more developed countries, or countries whose healthcare is actually very good, that include even genetic screening for certain diseases and screening for diseases like Down syndrome. But because of the current situation of our country, that might not be available. So some of those tests would have to be outsourced. But I'm glad that you have told us that there is currently ultrasound screening, and this is available, even though it's concentrated in the towns. But this is something that mothers in South Sudan can access. Thank you so much for that. So we'll go to Dr. Jane before we come back to Dr. Victoria. So Dr. Jane, Dr. Ayak has talked a little bit about screening of chronic diseases in pregnancy. So please just give us an overview of what some of the major chronic illnesses that are screened for, what is their possible prevalence in South Sudan if there is information out there, and why is it important to screen for these specific diseases?
Well, I would first want to appreciate the two outstanding doctors that talked before me, three of them, Dr. Victoria, Sandra, and Dr. Ayak. They have outlined really what is going on in South Sudan. Basically, if anything is happening to a woman, a mother, it's happening to the population. And they have outlined that very well, and I'm proud of them. So basically what I'm going to say is divided into three sections. So non-communicable diseases screening that is done to everybody above the age of 20 or 18, and then specifically some that are done for male and female from the age of 40 to 50 and above. Most commonly in South Sudan, I cannot find the data. For example, the surveillance that they're talking about is there, the systems are there, but the data is not published. So it's not common that you can find really the data of everything, but the data of the most prevalent diseases there, we can say it, mostly the last 17 diseases that are, frequently monitored, and it's disturbing, and they're mostly the causes of the detrimental effects. So I would say, let's start with the simple things. High blood pressure. High blood pressure, everybody over the age of 18 needs to be screened for high blood pressure once a year or twice a year as needed. This is non-invasive, uses a blood pressure cuff in your family doctor's office, general practitioner, or anywhere that you go. It can be screened. It's non-invasive. Screen it by somebody sitting down, standing up, and laying down. You can get an accurate blood pressure. Wait for the person to take at least a 20-minute rest after they have worked for long or they have been running, got off of transport, before you take it so you can get an accurate blood pressure reading. We have different kind of blood pressure machines that you can use. The cuffs are the most accurate than the automatic ones, but you can use any kind of blood pressure machine you have. As long as the person has rested for 10 to 20 minutes, you will get an accurate blood pressure. Again, standing, sitting, and laying down. That can give you an assessment every year of how the blood pressure of the person is. We also have physical exams that we do annually. Physical exams annually that you do can elicit a lot of things. For example, blood work that you do with physical exam, including screening for cholesterol, cardiovascular diseases, diabetes. Those are very, very important to understand the person's risk factor, especially if obesity is involved or if malnutrition is involved. In those blood work, you can see what the person's risk factor is. You can calculate for the cardiovascular risk factor in the next 10 years. You can calculate the risk factor for a stroke in the next 10 years. With also annual physical exam, you can screen for BMP or CMP as well as the CBC. For anemia, you can check anemias. You can check other anemias that are not common related to also the pregnancies or related to other malnutrition or related to other kind of problems such as thalassemia anemia. So you can check the kidney functions, the liver functions, and everything in the BMP. In that way, you can advise the patient, guide them in their diet, in their lifestyle, to avoid other things that may be detrimental to them. You also have other screenings that you can do depending on the patient's age. So for example, if you have a 40-year-old female presenting to you with no family history of cervical cancer or breast cancer, you're still going to have a pap smear done, you're still going to have a mammogram done every year. Pap smear is recommended according to the American Association of Gynecology once a year for 3 consecutive years. If it is normal, you now do it every 3 to 5 years in a person having one relationship, one monogamous relationship. If you have more than one sexual partner or you're a sex worker, then your STD screening will be done more frequently, probably every 6 months if you're a sex worker, or more than that. But if you have only one relationship, one monogamous relationship, and you're a woman over the age of 20, you should have a pap smear 3 times consecutively every year, normal, and then once every 3 to 5 years. Now, if you do have a history of breast cancer in your first-degree family means your mother's side, your father's side. That means it's either your aunt from your mother's side or your aunt from your father's side. So that's a first-degree family. Your screening will have to start earlier and periodically, as indicated. We have other screenings, for example, when you're at the age of 50, everybody has to go through colonoscopy screening. Because of the rate of colon cancer, colonoscopy screening is indicated for everybody who is at the age of 50. That is a screening. Now, if you do have family history, which is a first-degree family that had colon cancer or stomach cancer, then it starts early before that. Mammogram is very important because of the risk of breast cancer, especially in women or areas where women drink alcohol, use birth control, they go on high altitude, and they smoke. So it's very important, even women who have first family degree that have a history of breast cancer. It's very important to start breast cancer screening at the age of 40, and again, early if you have a first family degree that has that. Other screenings for men also include prostate screening, PSA, at the age of 40. Other men can start it early if they have first degree family member who has had it, but the prostate cancer has got a very good success. 99% of the prostate cancer is treated, and the men live longer. They are lifelong prostate cancer risks are reduced very much. Other problems like cholesterol also. Because cholesterol issues leads to cardiovascular issue, and cardiovascular issues are very, very detrimental. And I know that in South Sudan, a lot of our people, especially our community, Zoltan Bukungido Rukwezere Bewaga Bukunindo had attack or Aya stroke galwalai desamamu. But the last time the patient went to the doctor was only when he was sick. He has not done any screening, or she has not done any screening. So there is a lot of communicable diseases that needs to be screened, and they're very important, but these are the few that are non-invasive, easy to check, and easy to address. Blood pressure is the most common one. Our people have a higher risk. South Sudan doesn't have specific data. Uganda has about 30% of the population has blood pressure issue. Khartoum is documenting 20 to 25% now. So South Sudan should be within that average, and it is a silent killer. People should be screening for that every year, at least. Screen for diabetes, screen for blood pressure, screen for cholesterol every year. And then women need to have the pap smear and the mammogram. Men over the age of 45 needs to start screening for the PSA, that's for the prostate cancer, and to screen for colonoscopy if possible. Thank you.
Thank you so much, Dr. Jane. I think you've given quite a wide array of diseases that should be screened for. And I like the fact that you've emphasized that a regular screening should actually be done, especially when it comes to going to the hospital for a general checkup. I know our people generally don't have that culture of just going when they're not unwell to get themselves screened, but it's important to do it because there are things that can be picked out early and intervention can be done early. So we'll come back to you for a bit more detail about a screening, especially for diabetes, and screening for breast cancer, because I think people are very, very interested in hearing that. But let's go to Dr. Victoria now. Dr. Victoria, from a Ministry of Health perspective, has screening and surveillance data been used to direct efforts towards specific disease conditions? And which are these specific disease conditions? What have been the reasons for targeting these disease conditions, and what has been the impact? And maybe you can also go into a bit about the COVID-19 pandemic that is facing South Sudan. Right now, we are on what is being described as the second wave, and what capacity. You know, we can do surveillance and screening all we want, but what capacity does the Ministry of Health have to respond to alerts of outbreaks or increase in cases that are received through surveillances? And what are some of the challenges that they have experienced? What do you think can be done differently? So has surveillance and screening data...
Yeah, thank you, Dr. Ann. Yeah, definitely, data from surveillance has been used by the Ministry of Health. We've had an outbreak of cholera in 2020. Alerts came, like I said earlier, we have a robust IDSR system. And in the 10 states plus 3 administrative areas, we have IDSR officers bringing alerts on daily basis. We have come a long way. At the moment, at the Public Health Emergency Center, Operation Center, we have a data unit that have recently been built with support from partners. And we have upgraded to DHIS2 to cope with the countries in the region and to catch up with our sisters in the region. So very soon, those data will be reported through DHIS system and be centralized so that when you are in Juba, you are able to know what's happening in Awil or Raja or whatever, which is a milestone. So yeah, like I said earlier, using the data, we have a pool of experts, public health experts and epidemiologists who track and analyze data and inform policy and programming. And as a result of that, we were able to contain the cholera outbreak of 2020, the measles outbreak of 2020, I mean. And as of recent, due to the alerts and due to the data, we were able to administer oral cholera vaccine to some parts of the country. There have been outbreaks of hepatitis E in some parts of the country, and as a result of the surveillance data being used, they were able to be contained and tackled. Recently, there was, because of following up of the data, we are able to detect a surge in the cases of COVID-19, and that has informed the National Task Force to sit and review some strategies, and has led to the recent lockdown of that was done on the 3rd of February to the 3rd of March. It was because of the results of surveillance activities and data from surveillance, and because cases were increasing. I know you have mentioned earlier that there is a new wave coming up. Because of the new wave coming up, the National Task Force have recently developed, established a committee called COVID Audit Committee. The COVID Audit Committee is tasked to go around institutions, public and private, to see whether preventive measures are in place, check whether there is hand sanitizers, hand washing facilities, whether people are social distancing, physical distance or no, whether they're wearing face masks, and try to tackle those preventive measures and enforce them. They've also been encouraging awareness raising through media, and they have incorporated media personnel to the committee. They've also been pushing for reduction of stigma, because COVID-19, unfortunately, is becoming stigmatizing like HIV and the other diseases in the past, like leprosy. People are now scared to say that they have COVID. Someone will be having COVID symptoms and say, no, it's just simple flu. They don't want to accept it's COVID. So reduction of stigma is very important. Risk communication is very important. And these are all policies and strategies that has been adopted by the Ministry of Health to tackle and to respond to the surge of high cases of COVID-19. Also, because of the new strains appearing in South Africa and in some parts of the region, the Ministry of Health has also been sending samples to neighboring Uganda to do the genomic studies and make sure whether we have the new strain or not. Fortunately enough, up to now, we have not had any result coming back positive for the new strain. And we keep sending samples for genomic studies to make sure that we don't have the strain. The Ministry of Health is also embarking on setting up a committee that looks into procuring the AstraZeneca vaccine. I'm not going to go into that into details. And like we said, you've also asked whether we have the capacity. Yes, like Sandra mentioned earlier, we've had alerts, daily alerts through the call center. We have a fully established rapid response team that have been trained and have extensive training. And we have the case management teams, which are doing case management as well as home-based care. And we do have the capacity. We've learned a lot from the Ebola response, like what Sandra mentioned earlier. And actually, all the existing infrastructure currently being used, like the Dr. John infectious disease, were supposed to be used for the Ebola disease. So it was a blessing in disguise, and now we are using those facilities and infrastructure. And we have invested in our teams. We have also done a lot of training for data managers and data clerks, and county health officers have been trained on use of DHIS2, so that they send the data centrally. And hopefully, in the near future, we'll not have to struggle with the data, and we'll be able to use the data timely to inform policy and also to set programs that are interventions. Challenges existing, of course, are there. Funding is a big challenge. At the beginning of the response, there was a lot of pooling of funds coming from partners and from well-wishers to support the COVID-19 response. Currently, that funding has staggered. There's no more funding to support the response as we are expecting. Also, human resource is an issue. Turnover of staff turnover, and human resource is a problem generally in the country, in the health sector in general. And I think, and being a health professional, will be really aware of that. So human resource and funding is our biggest challenge. Mobility of the rapid response team. Partners have been supporting renting vehicles for the rapid response team to move, and this has also staggered, and mobility of the rapid response team is also a problem. It's a challenge. So these are a few challenges that are existing, and we are hoping to address those challenges. The National Task Force is working day and night to make sure that things are into place. And we keep our fingers crossed, and we just have to continue advocating and for more resources and hoping that things will improve.
Thank you so much, Dr. Victoria, for that overview. And it's great to hear that there's actually some capacity, even though in some instances we are using our neighbors and their labs to help us check whether our strains have evolved in any way. And I am happy to hear that we actually have rapid response despite the fact that logistics and mobility is an issue, and funding is also an issue. And Dr. Jane was actually asking whether PPE is also a challenge. You know, we have to protect our doctors and our people in the healthcare sector. Is this something that the Ministry of Health is also experienced in terms of personal protective equipment challenges in that?
PPEs with the COVID-19 response and the COVID-19 funding, there've been a lot of support with procuring of PPEs, as well as also donations for PPEs. And even the Global Fund has put in some money for COVID-19 to procure PPEs, and also to procure two gene expert machines, high volume, that test a big number of tests. And at the moment, we're, like you said earlier, that we're using our neighboring countries. We do have the PCR in country, and we have the gene expert as well, used as a multi-diagnostic platform for testing viral load for pregnant women, also for EID, early infant diagnosis. We use it for TB, for HIV, and we even use it for Ebola and for everything. It's kind of a multi-diagnostic center. So we do have the infrastructure. It's only that we've been sending samples for quality assurance to neighboring Uganda, and we do even have quality assurance and external assurance sent to other places outside South Sudan.
Okay, thank you. Thank you for that information, Dr. Victoria. It's great to know that we have some capacity for the testing, and that is great information to hear. So, Dr. Sandra, if you could please come up on screen again. We've just talked a bit about the issue with the COVID-19 cases rising in South Sudan. For the information of our people who are currently there, what criteria is being used for testing or screening, and when should one as an individual go for testing? And in terms of surveillance, if you can expound a bit more on what Dr. Victoria has said, what is being done in terms of surveillance, and how is this aiding in the control of spread? Dr. Sandra.
Okay, so allow me to just join with the audio and to keep my camera off to ensure the connectivity goes on. So in terms of COVID-19, of course, we have different surveillance systems that are currently in place. Of course, we have community-based surveillance, or what we call the active case searching, where community healthcare workers are trained on going to the communities from house to house and educating them on COVID-19 and picking up if anyone has come up with any of the signs and symptoms of COVID, and then reporting that. So we have community-based surveillance. We have what we also call the sentinel site surveillance, which is another form, another type of surveillance. We have the active, the passive, and we also have sentinel surveillance. So sentinel surveillance is in certain healthcare facilities around the country. Whoever comes to that healthcare facility for whichever medical condition or medical care that they're seeking, if they fall or if they exhibit signs and symptoms of COVID, then they will be screened for COVID as well. So that's with sentinel surveillance. We have the call center, which is the number 6666 or quadruple six as we call it, where individuals can call to report themselves or their family members or friends or neighbors if they have or if they are experiencing symptoms of COVID. And of course, all this information will be collected, and at the national level, we deploy the rapid response team to go and to collect samples from these individuals. And of course, at the state level, we have the state rapid response teams. So all these different forms of surveillance for COVID-19 are actually ongoing. Even the IDSR is active, and the EWARS is also active in picking up COVID alerts as well, whether these alerts are for live cases, live individuals, or these alerts are for people who have passed away or succumbed to the illness. So maybe just quickly, I believe most of us already know the signs and symptoms of COVID, which is more or less the sign and symptoms of any flu-like illness. But in addition, you can have a very high fever. You can have other symptoms like nausea, like diarrhea, for example, which are a bit peculiar and not really like just a flu. Or you can have difficulty breathing, or what we call symptoms of respiratory distress. So these different, what we call case definitions, if you're a suspect or you're a probable case for COVID-19, you need to be tested. So at the end of the day, you can either have the clinical diagnosis where we think this person has COVID, but then we have to confirm it by the lab, which is where the laboratory comes in and does its part in surveillance as well. So for now, of course, most of the cases that are being detected, almost 80% of cases that come in every day are detected from the pre-travel screening. So these are individuals who are willing to travel. They don't have any signs and symptoms, and they just go for a screening so that they can have a negative certificate to travel, and then they unfortunately they are tested positive for COVID. But again, we have the call center, we have the RRTs, we have the healthcare facilities and the sentinel sites, all of which are picking up cases and detecting cases of COVID-19. And we also have the contact tracing. Contact tracing is very vital. It's really important in also picking up cases of COVID-19. In my case, for example, I'm going to use myself an example. I was a contact of 3 to 4 people who tested positive on 4 consecutive days. So out of contact tracing, I got my sample, I went for a screening. I didn't have any symptoms. I went for a screening and I was tested positive for COVID. And it was only the next day that I started showing signs and symptoms. So there are all these different methods
Sorry, it seems like Dr. Sandra, are you still there?
Yeah, I'm still here. So there are certain categories in the community which we prefer that we should screen them for COVID-19. We have vulnerable groups. We have people with chronic diseases. We have people of age. We have people with who are immunocompromised. For example, if we have people who not like the pre-travel screening is like routine for those willing to travel, but we also recommend that other high at risk individuals, like if you're a healthcare worker, maybe you can go for a test every 2 weeks just so you know your status. And because also we have a lot of cases who are asymptomatic. So here in COVID-19, we have both active surveillance contributing to detection of cases. We have sentinel site surveillance contributing, and we also have screening. So I think we already know the difference between surveillance and screening. Surveillance, when you go and you look for the disease in people who may have it, but screening, you're looking for a disease in people who are more or less normal. They're not sick. They don't show any signs and symptoms, as Dr. Jane was saying. So screening, we're looking for something in someone who is practically normal. So for COVID-19, there is ongoing screening, there's ongoing surveillance, and I think a lot of cases are being detected. almost between 20 to 30% of samples that are collected every day end up testing positive for COVID-19, and a large proportion of them still remain to be asymptomatic. So I believe, and the Ministry of Health is continuing this effort, both at the national level and the different other localities where we are experiencing COVID, a high peak in COVID cases as well. And of course, not to rule out or not to not mention the points of entry. Points of entry is also a form of screening. So we see people coming in at normally at Rank and Juba International Airport, and they're being screened for temperature. So the thermoscan will not really tell you if this person does have COVID, but it will at least pick those who probably have it. So these are all the different forms of screening and surveillance that are ongoing currently for COVID-19. I think maybe some of the challenges we just have there is the issue of reporting. As we mentioned earlier, the issues of underreporting. We have a large number of people who are asymptomatic. We also have the issue of stigma, as Dr. Victoria mentioned. We've had an experience of convincing people who are cases to inform their contacts that they have tested positive so that they could be swabbed as well. And we've had issues with contacts who have been listed accepting to be swabbed. So stigma and increasing awareness on COVID-19 and the public health measures and ensuring that people are wearing their masks and using their hand sanitizers and washing their hands is crucial. And it is something that the Ministry of Health has undertaken, and we hope, and we are going to see in the next coming weeks that these measures are being enforced and being put in place for the greater good, for the safety of those who are actually at risk. If you are young, maybe you may not fall in the category of getting a severe form of the illness, but then you're putting other people at risk as well. And also maybe just to point out that over the last 2 to 4 mortalities or people who have passed away to COVID-19 were actually in their 20s in South Sudan. So we should not say, oh, because I'm young, I'm not going to get COVID, I'm not going to die, etc. So we all have to be careful. And as the ministry and the partners continue to conduct active surveillance and active screening, the community also have to take their part in preventing the disease and preventing the further spread of the disease to the vulnerable people who might really be affected by it. So over from my side. Thank you.
Thank you. Dr. Sandra, there's a question for you from Dr. Nyal Tulam before we go to Dr. Jane and talk a little bit about chronic illness. I know we're considering so much on infectious disease. So Dr. Nyal is asking, do experts on the ground have a sense of what is behind the recent rise in the COVID-19 cases in Juba? Do you maybe have an answer to that, Dr. Sandra? And maybe Dr. Victoria can help if she has an idea.
Yeah, well,
okay. Thank you.
For the recent rise in cases is the reluctance of our people to observe preventive measures, because at some stage people are saying there's no more corona, and people stop using face masks, they don't observe social distancing, the parties have gone up again, the weddings, the funerals, people are assembling in big numbers, and nobody is adhering to the precautionary measures after the lockdown was lifted. And I think that one of the reasons that has contributed to the rise of cases. Secondly, one other reason could be the new wave of infection coming back that has led to the rise in cases. And I'll give an opportunity to Sandra to also complement.
Dr. Sandra?
Thank you, Dr. Victoria. I think she more or less summarized the answer to the question. So yes, the subject matter experts are told they're not complete, like 100% sure. Of course, we are attributing most of the cases to the new strains of or the new variants of the virus that may have come into the country, specifically after the festive season and people who have traveled abroad and coming back into South Sudan. It could be the reason, but we are waiting for the final results of the genomic sequencing. So different samples from different places, Juba, Abyei, Wow, from different locations and different counties in South Sudan. These samples have been shipped to UVRI, and they're going for genomic sequencing. Until we get the results of the genomic sequences, we cannot really confirm or 100% attribute the rise in cases to just the new variants. But as Dr. Victoria mentioned, there has been a huge reluctancy and huge non-compliance from the public to COVID-19 preventive measures, especially that we initially had a peak in June, July, and then we saw a drop in cases. We were getting like 8 cases a week or 1 case per day. So and there were no deaths really at all. So I think these are all factors that contributed to an increased reluctancy from people, because I think for us, people only fear death, and because they haven't seen many people die of COVID-19 here, probably people thought, oh, it's not very dangerous. But over the last few weeks, we have experienced like a high number of cases and a high number of deaths as well. So the National Task Force have issued communications and circulars on adherence to public health measures, and I hope that the public actually implement and take their part and their responsibility in applying these public health measures. I hope I have answered the question. Over.
Yes, thank you so much, Dr. Sandra and Dr. Victoria. I think that has cleared up a few things for the rest of us who are wondering what exactly is happening in Juba and in South Sudan in general. Now, to just shift a little bit from COVID-19, I know it's at the front of our minds, it's always in front of us. Let's talk a little bit about some of the cancers as part of the chronic illnesses that affect individuals in society. So, Dr. Jane, maybe you can give us an overview, especially of breast cancer, which is one of the leading causes of death in women. Who should be screened, and how is this screening done? And for those who are able to examine themselves, what do they do when they find a lump? And what do the doctors do when they come to them with a lump? And what are some of the next steps that are taken by clinicians after detection of breast cancer? And if you can also give us some information on cervical cancer for the same, what kind of screening is done, and what are the steps that are taken once it is detected? Dr. Jane.
Thank you for the opportunity again. So let me start with breast cancer. Breast cancer screening really starts in the United States at age 40. But that is only for those who have no risk factors and they present with no family history, no first-degree family history. Again, the risk factors that we look at include the smoking, birth control use, which is long-term birth control use, especially which are not like IUDs or other things. And we screen those women from age 40, not because they have breast cancer, but just as a screening every year. But once they come and say, I have a lump, I have this, we do something different. Not only mammogram, these days we have 3D mammogram, but we do an ultrasound plus the mammogram, which is the 3D. So that turns from screening mammogram to diagnostic mammogram. So they look at specifics of what it is. If they see a mass, how big is the mass? What is inside it? Can you see in it? And the ultrasound is to look through and see what is inside it. How is it looking? And then if the mass is really what the person has felt has been seen in the ultrasound and the 3D mammogram, then the patient will be sent for biopsy. A biopsy is done to understand exactly what kind of pre-cancer cells or cancer cells is seen in that breast tissue. It helps to stage it, and then it helps also for the genetic cancer, genetic testing, so that you can design and tailor a specific treatment to that person. We also do some things, including CA 125, testing for blood to see if there is cancer in your blood. Now, if the stage is more than stage 2 or 3, then we have to also send the woman for something called a PET scan. That is a whole body scan to check if the cancer has not spread to other parts of the body. So, for example, if it starts in a breast cancer, has it spread to the cervix? Has it spread to the liver? Has it spread to the lungs? Did it spread to the spine? Did it spread to the brain? So if that is not there, that makes it easy to understand the treatment and what is tailored. For example, the doctor just needs to go in there, remove it, does not need chemo, does not need anything. Does the doctor have to remove the whole breast? Does the doctor have to remove the breast plus the lymph nodes, or just have to evacuate that mass and the rest of the things are fine, or doesn't have to evacuate any of them, start chemo before doing surgery? So it really helps to tailor that. Those who have, again, first degree family members that had breast cancer, for example, if my mother died of breast cancer, I need to show up at age 30 or before that. Or if I give birth to a child and I'm not breastfeeding, I'm having issues, or I'm having problems, mastitis with my breast early in life, I need to show up to have checkup. That's very important. Again, cervical cancer. Cervical cancer now, for people who are younger and in other countries, as I'm privileged in US, you have the opportunity to get a HPV vaccine, Gardasil 9, from age 9 to 26, and now they've taken it to age 45. That is to prevent HPV, both for females and for males, now available. Because HPV is one of the causes of cervical cancer. Cervical cancer is detrimental in a lot of ways because sometimes it's also silent. We don't dictate it, we don't know it. Women come with very, very mild and non-significant issues. Sometimes it says, oh, my period just ended and now I'm spotting again. I'm having some bleeding after sexual intercourse, and I'm having some rash. I'm having something. So then the healthcare provider does a pap smear screening to see what is really going on. You check for all STDs, you check for herpes, and you screen for cervical cancer. And then it can be dictated. Sometimes it's a silent, you will not dictate it. Sometimes they will have some minor pain and that bleeding, spotting. And women who are not in childbearing age, a lot of time present with irregular bleedings. They come and say, oh, I am in menopause, but now I have started my period again. No, you do not. You do not start a period again after menopause. That is a cancer. That is something else. So those screenings really try to help to understand and bring to light what is happening with the women's body and to get them care or intervention quickly. Again, in cervical cancer, that does not end it there. If it is abnormal, you are sent now to the OBG. Your family doctor has done that. If it is abnormal, then you're sent to the OBGYN. The OBGYN will also do something called colposcopy. That is, she's gonna scrape the cervix and do like a biopsy to make sure they check and understand what that cells are. So if they check and understand exactly what kind of that cancer cells it is, then the treatment can be tailored to it. One thing I have to say is that there is a lot of people facing different kind of challenges. I have lost somebody, a dear friend, lost very close to me in her early 50s because she had cervical cancer. When she went for the treatment, the doctor advised to remove the entire cervix and uterus. She said no because she wanted to have a baby boy. She wanted to have a boy. She didn't have a boy. She kept the uterus, and it came back someday again to haunt her silently, and it did kill her. So follow what your advice is. And then I also have somebody I just talked to this week in the United States who was found to have a small lump in the breast. Yes, the biopsy has been done. It's recommended that biopsy has not been done. It's recommended that both of her breasts be removed before even biopsy. And I said, this is not right. This doctor is not doing the right thing. You need to go through the process, do the genetic testing, the genetic counseling, get a PET scan, because she also has a lesion in the brain. So look at all that first before you can have both of your breasts removed. Maybe it's not even reasonable. Maybe the breast cancer is not even in all your body. Maybe it's not even metastasized. So get a PET scan, get all that. Most importantly, out of all this is, if you are diagnosed to have any one of those, anything that has a cancer to the end of it, get a second opinion. Get a second opinion. If there's anything you're not going to take from this, get a second opinion. Ask all the questions needed. Understand the plan of care before you move to any intervention, because any intervention after that is going to be invasive.
Great. Thank you, Dr. Jin. I will come back to you so that the men don't feel left behind, and we will talk a little bit about prostate cancer and who is screened for that. But for now, we will go back to Dr. Victoria. Unfortunately, we have lost Dr. Ayak. We hope to be able to engage her in another discussion in the future if she's not able to come back up. So, Dr. Victoria, there has been a campaign to encourage screening and subsequent treatment or follow-up for hepatitis B. And recently, the Ministry of Health launched the hepatitis B strategic plan. What prompted this campaign, and is testing or screening for infection available? How is it done? Who is tested, and why is screening for this virus important?
Thank you. And actually, the campaign came as a result of surge in number of patients coming with complications at late stage, and that has been was prompted after a situation analysis was conducted by the Ministry of Health, doing desk review, going through records in the hospitals, going through surveillance data, and it was found that it's a real issue in South Sudan. And as a result of that, because of the data, because of the surge in cases and number of deaths due to complications of hepatitis B particularly, the Ministry of Health embarked on developing a strategic plan and strategic documents to use them as instruments, not to give them to clinicians to guide them on management of cases of hepatitis B and C. And mainly testing is happening, unfortunately, is happening in private sector, not in the public sector because of the resources. After the strategic plan development and the guidelines, there was a discussion with the Ministry of Health to establish a hepatitis unit in Juba Teaching Hospital, and perhaps scale it up to WOW Teaching Hospital and Malakal Teaching Hospitals to be like regional hubs for treatment and management of hepatitis disease, which has not happened yet. We've been doing a lot of consultations with other funding bodies like and also other support research institutes like the Lugai Foundation. We have engaged with them to support us in trying to see how we can support the program, because it's not funded. Unfortunately, this needs domestic resources. It needs domestic resources from the government, which the government cannot do at the moment, especially with the current economic crisis, coupled with the pandemic situation. The country is not in a position to provide domestic funding for hepatitis at the moment. There was an initiative done by the Egyptian government called President Sisi Initiative to Treat 1 Million African, and that initiative is targeting hepatitis C. And sometimes last year they did the campaign in Juba, and they treated a number of people, especially with hepatitis C. The Egyptian clinic in Juba is also doing screening and treatment for hepatitis C, but most of the treatment is happening in private facilities. Treatment is very expensive. Not everybody can afford it. Screening, a rapid test is being done at the hospital and at private as well. But viral load is very, very expensive. And before, most people were sending samples to Khartoum or to neighboring Uganda, and the turnaround time is quite long. It comes after 6 to 7 weeks. But now, luckily, there are some, with the COVID, there are some private clinics like Queens and Nujum who has now have PCR in the country, and Juba Medical Complex also offering viral load, and Oromo Clinic is also offering viral load. So mainly there are some private facilities nowadays who can do viral load in the country, and we're planning a dissemination of the guidelines and the strategic plan to our clinicians and help them use proper ways of screening and treatment of the hepatitis. So that's why there was a campaign for hepatitis. But unfortunately, hepatitis program in the country is not funded at all, and it's treatment and screening and testing happen mainly in private facilities. But the Ministry of Health has identified hepatitis as a priority, is one of the priorities. We're still hoping that we will do something for the hepatitis. It now have a program next to the HIV department, and we're trying our best to mobilize resources, domestic and external, to support the program, and perhaps use integrated approach using the existing resources on HIV to piggyback and support the hepatitis program.
Thank you so much, Dr. Victoria, for that overview. It's important to note that hepatitis B is one of the main causes of chronic liver disease, and sometimes can also lead to cancer. And that is why it's important to actually screen for it. Dr. Ayak seems to be back with us. Hopefully she can continue the conversation Dr. Jane had started on cervical cancer and what the approach for the obstetrician and gynecologist is to it, and how does early detection impact on progression of disease or treatment. Dr. Ayak, are you able to expound a little further on how, as an obstetrician, you approach cervical cancer and what the impact is on early detection, on treatment and progression? Dr. Ayak? Okay, unfortunately, Dr. Ayak is on the screen but is unable to respond. So Dr. Victoria, maybe we can come back to you so that you tell us a little bit more in relation to infectious diseases. I know you work for the HIV STI department in the Ministry of Health, and the HIV pandemic has led to high mortality and morbidity, and South Sudan is not an exception. So what are the strategies that the Ministry of Health has put in place to increase testing, early intervention, and to create awareness on HIV?
Well, the Ministry of Health has scaled up its testing services. We have a number of facilities offering testing in the country, HTS services, and we have decentralized our services. Previously, we were only having the bigger hospitals, but as of recent, we have decentralized our service to primary health care. And even as we have gone as down as to the community, to do testing in the community, we are embarking on doing targeted testing because of the resources and because also of the yield. So we're doing targeted testing to key populations, female sex workers, men in uniform, and TB presumptive to get to have better yield. And we also have worked with our network of people living with HIV, civil society, and this network of people living with HIV are helping us with the stigma, which is one of our biggest challenge hindering progress of HIV treatment and testing in the country. Many people are scared to come to testing, and even when they're tested and they're found positive, they're scared to be linked to care. One of our major challenges is self-stigma, and people living with HIV have worked with us over the years. They have worked to speak about their status, to declare their positivity and positive living. We have used them at the clinic as adherent counselors, so they help people who are newly diagnosed to be on treatment and to stay on treatment, especially that now we have, over the last 3-4 years started test and start. Like in the past, we used to test and wait for CD4 count and whatnot, but now we just do test and start or test and treat, which is a new phenomenon that has been adopted by WHO and more all of the member states. And nowadays, when you are tested today, you can start treatment immediately without waiting for anything. And that poses a challenge because sometimes people are hesitant to start treatment, and that needs a lot of pre-test counseling and post-test counseling, and also adherence counseling to stay on treatment, especially in the first 3 months, because you are new to it, you are still living in denial. People need counseling and whatnot. So we have been using these people living with HIV as adherence counselors. We've also embarked on using modalities like differentiated service delivery, giving multi-month scripting for 3, especially with this COVID situation, to avoid people living with HIV coming to facilities. We've been advocating for multi-month dispensing, 3 to 6 months for those who are on treatment for a long time and are stable with no complications. We've also rolled out the new drugs, the dolutegravir, which has lesser side effects, and it's now in our guidelines, and we have rolled it out in almost 95% of our facilities. We've also scaled up our treatment services from 20-something in the last 3 years to now almost over 100 facilities. And we're also giving mobile ART clinics to people in the community, because we have found that facility-based approach on itself will not help us to reach everybody. So now one of our modalities used is to embark on community ART refills and community treatment, and giving the service to the people at the community level. So these are a few things that the Ministry of Health has worked on. Combating stigma, we have developed IEC materials, working in collaboration with the South Sudanese Commission and the Department of Health Education in the Ministry of Health. We're doing a lot of awareness campaigns, awareness through radio. We're also using opinion leaders, chiefs, and the Boma Health Initiative, which is the flag bearer of the Ministry of Health, a community model of care designed by the Ministry of Health to deliver service to the community. The Boma Health team are also having someone in charge of HIV and infectious disease, so that they can be able to reach people as lowest as to the lowest level of the government, which is the Boma.
Thank you, Dr. Victoria. Some of the strategies you've mentioned definitely will increase testing, and especially with the availability of treatment in the community and the availability of testing in the community, the reduction of stigma, and the introduction of what we refer to as peer counselors, people who are passing through a similar issue and are able to encourage others who are experiencing the same and who would like to be also tested and determine their status. So some of the questions that are coming up from the audience and from some of us is, what percentage, do you have any data on what percentage of our population is affected with hepatitis B and C, and whether treatment for hepatitis is free in South Sudan or available? As you mentioned, HIV treatment and ARTs are being delivered actually to the community setup. But what happens when it comes to hepatitis B and C? Is this available? And what is the percentage of our population that's suffering from it?
Like I said earlier, we don't have any population-based studies done on hepatitis B and C. It was just a situation analysis and few data from facilities and from private sector that don't reflect exactly the clear picture of the epidemic in the country. But we have more hepatitis B than hepatitis C in South Sudan. Hepatitis C is quite low; the prevalence is low compared to hepatitis B. And unfortunately, most of the cases of hepatitis B come with late complications, like you said earlier, with either hepatocellular carcinoma or liver cirrhosis. They come at a very late stage. Unfortunately, also, we don't have any free treatment for hepatitis B and C. The Egyptian clinic, like I said earlier, was offering treatment to hepatitis C, and they've done a campaign with free treatment, was just one of thing. But at the moment, everybody buys the drugs, which are very, very expensive, and that's a big challenge posed on a lot of people in the community. I also want to mention regarding the modalities for HIV that we are now updating our guidelines and introducing self-testing for a specific group key populations in the community, the elites and people and also for female sex workers, because some people don't want to come to facility. Also, it's one of the ways to combat stigma. Self-testing is one of the modalities we're trying to introduce in our new guidelines.
Thank you for that overview, Dr. Victoria. Dr. Ayak, I don't know if you can hear me. Dr. Ayak? Dr. Ayak, I had wanted you to just further expound on the role of the obstetrician and gynecologist in the detection of cervical cancer and what the impact of early diagnosis is on disease progression and treatment. Dr. Ayak? Dr. Ayak, you're currently muted. Okay, unfortunately, the internet in WOW is giving us quite a lot of issues, but that's okay. I'm so glad that Dr. Ayak was able to try and log in and answer a few questions. So we will go over to Dr. Sandra. Dr. Sandra, I know you've talked a little about how data collected from surveillance has impacted on certain service provision. If you can expound on a little bit more on that, how the data that has been collected from surveillance has impacted on service provision or programs for control of these diseases that are under surveillance, and what are the challenges of using data to influence health policy or lead to change in healthcare provision, and what are some of these solutions to these challenges? So there's always this issue for how to translate data to impact in terms of changing service delivery. What are some of these challenges that you have seen in your practice as a public health professional? Dr. Sandra.
Thank you, Dr. Anne. At least I got that question clearly, so that's good. So with regards to how we interpret or we use data that is collected from surveillance for public health policy and other measures for controlling some of the epidemics, or for putting plans of action and other control measures in place. I think this is something that we have been doing in South Sudan. I think since maybe even before the implementation of the IDSR way back. So I will use an example, say for example, cholera. So we've had in some locations there was no access to healthcare in some of these health facilities, and because of an outbreak that has happened, there has been an increase in the provision of healthcare services that are not necessarily temporary, but whatever structures are put in place to control and monitor an outbreak, there's always a residue of these health structures that are left post the event, and these structures are always in place to later then be reactivated if another health event happens in that area, etc. I used another example earlier, our EVD preparedness and our EVD readiness program. So South Sudan has been involved in EVD readiness since 2016. So over the years, even with healthcare workers capacity building, with putting IPC measures in different healthcare facilities, you eventually find out that over the years, you are not just covering one disease per se, but you're covering a range of infectious diseases. Because if you do surveillance for EVD, you're not doing it specifically for EVD, but you're doing it for all viral hemorrhagic fevers. So you're covering a wider range of diseases by training and putting structures in place, and by actually training healthcare workers on detecting these events and reporting them, so that we can have an earlier response. I think our public health surveillance has become very strong. We recently had viral hemorrhagic fever from a small town on a border location with Sudan. I think I forgot the name of the location, but in less than 24 hours, the National Rapid Response Team was mobilized with the help of partners, and they went to the location, I think Siri Malago or something, and they went and they collected samples, and they came back to Juba, and within 48 hours, we received preliminary results. And fortunately, it wasn't EVD or none of the other viral hemorrhagic fevers. So this is one way where we say we have seen a great improvement in our early warning alert and response system, and in early detection of outbreaks and responding to such events. So like I said, in most of these activities are actually implemented at the healthcare facility level, whether it's a state hospital or a primary healthcare center or unit. So in those healthcare facilities, the ministry always ensures that the partners establish a cross-cutting activity, or to establish a system that will, even though has been established for a short-term benefit, like the infectious disease units we have in Juba, that they will actually stay for long and quickly be reactivated for an all-hazard response. So the Ministry of Health currently has a plan to establish infectious disease units in all the 10 states. So yes, we do have one in Juba only, but hopefully in the next few years we'll have IDUs established in all the 10 states, and thus improving our response. We will not need to transfer patients from Numali to Juba, for example, or transfer patients from other locations to Juba to receive better healthcare, and thus this way we are detecting diseases, we are rapidly responding to the control, to the case management, and we're also reducing the transmission of such diseases. So I believe that as the time progresses, and as our surveillance system becomes stronger and stronger, we hope that in a few years we will see that South Sudan is ready, with the full on-board all-hazard response detection response mechanism in place. And also, maybe to add to that, we have the risk communication and community engagement, which is really an integral part, because as a Ministry of Health, you cannot do these activities yourself. You and the partners, you can bring the supplies, the hardware, to conduct infection prevention and control, for example. But the community needs to take ownership of these initiatives. The communities need to be made aware. The different stakeholders in the community need to be involved in whichever disease we're talking about, whether it's diabetes or high blood pressure or cancer or infectious diseases. So the risk communication, community engagement, and behavior change communication are really integral. And I think I really encourage different doctors, healthcare workers to engage with communities in different forums where we actively conduct healthcare awareness and promote health-seeking behavior. Because until the community is aware of a disease or a health event, they will not actually be able to detect it. They will not be able to participate in controlling that specific outbreak or activity or event, I mean. So I think this is over from my side. I hope I have answered the question over.
Thank you, Dr. Sandra. I think you have even gone way over the answer to that question, and I thank you for mentioning the community involvement and creating awareness in the community, because that's very important. If they're able to pick out certain illnesses and also monitor trends, that would really help from a public health perspective. I like the way you have noted that certain investments in particular programs like the EVD preparedness ones and program, and how it has helped even with the COVID response. I think Dr. Victoria also mentioned that at some point, and the fact that particular screening for certain infectious diseases can actually screen for multiple other diseases and illnesses. And it's important to remember that some programs actually cross-cut against many diseases. So Dr. Jane, we had promised that the men would not be left behind. And therefore, as we wind up, please talk a little bit about prostate cancer, which is a major concern for older men. Who should be screened, and why is it important to screen for it? What are some of the tests that are used for screening, and how are they interpreted, and what steps are taken after screening? What are the consequences of late diagnosis?
So, as I mentioned, let me finish few things on screening. Number one, screening is basically done on different ages. And the recommendations depend on what age you are. So for example, if I am screening a child in elementary school, I'm going to ask about how many hours they sleep, if they drink milk, if they're attentive in class, and things like that. And if they have been able to make friends and how they play on the playground. If I'm talking to a teenager or I'm talking to an adolescent or a young adult, I'm going to ask about if their peers smoke, if they have friends that drink, use of drugs, wearing seat belts, use of sunscreens if you're talking to the white people here. So there are recommendations based on what the area is. If you're talking to adults, alcohol, drinking alcohol and other things excessively, smoking. If you're talking to young girls, talking about prevention of pregnancy, birth control, and all those things, STD screenings for both youth and adults. So all those things are part of screenings and they are very important. So bear in mind that there is different screenings for different ages. If I'm going to screen a 1-year-old in a physical exam, they do not need a CBC. But if I'm going to screen a teenager going for sports, I need to get a CBC to make sure they do not have other kind of anemias that they will fall. They do not have other kind of heart disease that they may be subject to and have a detrimental effect on the playground. So different screenings for different ages, and they're very important for those growth stages. Now for men, this is an important part. And the reason I think it's important for men is that I have had to have a lot of challenging discussions in the United States with men, basically not only fertility issues, but lack of performance between the age of 40 and 45. Few of them that have reached 50 years, they have dropped their age to 40s, but a lot of men in these ages in the diaspora have been having trouble and they have not been going to the doctors. So this is where screening comes in. Screening for men above the age of 40 is very important because of their manhood, because of their sexuality. And because when their sexuality is compromised, a lot of things happen with them. Mental health becomes a problem, divorces become a problem, and even some of them commit suicide and don't live anymore, and even have other detrimental effects on a family and a family separation. Number one, prostate screening starts at the age of 40, and it can start earlier if you do have a first-degree family relative that has prostate screening, has prostate cancer. How do you do prostate screening? Prostate screening can easily be done for an asymptomatic person that does not have symptom. You can just get a PSA level once a year at an annual screening. And you look for the normal levels and what the trend is. Now, if a male in his 40s, their normal would be different from a man who is in his 50s or his late 60s or 70s. So look for the trend and the changes of it. 2, men that have already problems with prostate, they will show up with either problems with urinary tract infection, dribbling, not able to sustain a stream of urine, not able to start it. They will have a lot of complaints. Sometimes the complaints are even non-specific. So the first thing the healthcare provider does is goes and does a rectal exam. The rectal exam is to feel the prostate. This is very uncomfortable for a lot of men, and they don't like it. And this is one of the reasons they do not go to do it. But this simple exam will allow the provider to find out if there is a spongy cushion. That spongy cushion tells you that there is enlargement of the prostate. Sometimes they just come with plain urine retention. They cannot pee, period. A Foley would be inserted to just allow them urinate, but then you have to find out what the real problem is. Now, if it is found that there is a prostate issue, there's several medications that you can put in to help them urinate and live a normal, healthy life. But if there is no prostate cancer, so if it is diagnosed as benign prostate issue, you can give them Flomax and they can just be fine. But if further tests indicate that there is a cancer, then they need to be referred to the urology or urology oncologist, and then they will be treated. Again, as I said, there is very good medications for prostate cancer. Since a lot of men are the one doing research, they have done a pretty good research on it and pretty good medicine, better than breast cancer for women. Now that said, breast cancer does not only affect women, it does also affect men, and gynecomastia also affect men, especially men who are taking fertility drugs or taking medications that help them to sustain erection or even be able to perform. Those medications include medications like Viagra and the rest of them. This man can develop gynecomastia, and they can also have breast cancer. So especially for this kind of men, they do not come really for screening. They come and present if they have anything. Some men will come and say, hey, I have prolactin. So that means I have milk from my breast. So that's when you screen them. Some of them will come and say, you know what, I feel like there is a pain here, or there is a swelling here. And then you check them, you'll find that they have breast cancer. Also, their survival has been good because sometimes they're good in reporting, but those who are not really good in reporting what is happening is really challenging. Lastly, to clear the dust for women, we used to have in the guidelines of self-breast exam performance, once a month at the end of your period, women were trained to go and do a self-breast examination. You want to put your hand at the back, that will give you a good area to examine your breast. Because of a lot of false positive results, a lot of women will do that exam before everything, and they're like, I found a mass here, I found a mass here. So a lot of women were going in radiation to check out to verify that mass, and there was a lot of false positive. So guidelines have come back to say that it is not recommended because the amount of radiation that the women go through for just a false positive is not proportional. So that guideline has been withdrawn or rescinded, though a lot of people still do it. In areas where there is no mammograms and things like that, I would still think that it is a useful guideline for the women to do the self-breast examination at the end of your period every month. Now, if I say this, then another woman in menopause will say, what about me? Again, the woman in menopause who doesn't have periods can also have breast self-exam once a month. Just pick a date once a month, check your breast, make sure you don't do it in a way that you're just looking for things that are not there. You're trying to find things that are different from your normal baseline. And I hope that helps. Lastly, for screening also, we do also screen children for cholesterol. Any child that is above the regular BMI for being at that age has to be screened for cholesterol, and we put them on cholesterol medication. Why? Because they are at risk of heart disease and even getting diabetes before their age if they are obese. For diabetes, long time ago, we used to say, Galde, you know, de marad al-Ghanianin, de marad nas Khartoum, marad nas al-Arab, la anno indum gurush, indum akel ketir, indum iya haja. Like in Dulwoti, Junub Zatu, we have a lot of people have diabetes, but we are not screening for them. So we need to have that also in the guidelines in South Sudan, that once a year, anybody that goes for physical exam above the age of 20 needs to get a test that is a screening for diabetes. I don't know what the screening they call there. We do the hemoglobin A1C, and everybody's hemoglobin A1C from 5.4 to 5.7, you are at risk. But until you are actually at 6.4, you will be officially diagnosed with diabetes and be given medication. If you're not at 6.4, at hemoglobin A1C, we do not give you medicine. And the first line of medication when you're pre-diabetic is therapeutic lifestyle modification. This goes well for diabetes, goes well for high blood pressure, goes well for cholesterol. That means your diet, your exercise, and your activity, your lifestyle, your habits, you change them to become a normal life, healthy person. And that reduces your risk of getting diabetes, reduces your risk of getting cardiovascular heart disease, reduces your risk of giving stroke, and in other words, extends your livelihood with living a long life and a healthy life. Thank you.
Thank you so much, Dr. Jane. Maybe 1 minute, you can just tell us some of the lessons learned in the diaspora when it comes to screening and surveillance for non-communicable disease, and what you think can be replicated in our country. Just a minute before we go into a round of conclusions and recommendations.
What I have learned is that our people are still afraid. They still have lack of trust in healthcare providers, and they still have difficulties communicating their issues. Though we have been talking a lot about screenings in the United States here, our women still have low turnout for mammogram, low turnout for cervical cancer screening, and very, very low turnout, especially for males, for colonoscopy and even prostate screening. So I really do not know how I can recommend this for somebody in South Sudan where they do not have even the facilities, the capabilities. But these are three things that I have outlined, being that we live out in diaspora, we eat the food here that is grown with all these chemicals. We drink the water that have been purified and processed with all these things. We use the medications, the pollution from the cars and everything that is here. We are at more risk than any other person somewhere else. And if you are anybody watching in diaspora, any part of the world where you are, you need to present yourself once a year to your primary doctor. It doesn't mean you have to be sick. Once a year, go in for a physical exam, have screenings done, and just go home. It will give you a peace of mind. It will give you a rest. Now, people in South Sudan, if you have a child going to school and is playing sports, make sure you take them to the doctor once a year to get that physical. If you have a growing child, once a year, make sure you go. Have the vaccinations done. Childhood vaccinations are very important. And if you have a woman older than 50 years, please make sure you get a colonoscopy done, because colon cancer is a killer. People who smoke, make sure you talk to your doctor. Find ways to get away from smoking. People who drink alcohol in excess, please talk to your doctor. Women who use birth control, think about it, because a lot of times you can prevent pregnancy by abstention. You do not need birth control. Not because I'm a Catholic, I'm saying this, but you can do without using birth control and be okay. So think about those minor things. Those who drive, wear a seatbelt. It can prevent you from getting a brain injury, traumatic brain injury, and being in a vegetative state. We do not have the facilities for that. So there are things that we can prevent. Do not do drugs. Stay healthy. You know, there's many things we can do. We can drink water instead of drinking excess alcohol. Just drink a cup, you will be okay. Thank you.
Thank you, Dr. Jane. Maybe you can we'll get back to you for the conclusion and recommendation. So, Dr. Ayak, are you there? I want to check if you can say one last word before we go off for your conclusion and recommendations. Dr. Ayak? Okay, we hope Dr. Ayak will be able to be more involved in future panel discussion. We will definitely contact her for that. So Dr. Sandra, if you can give us your conclusion and recommendations, and then Dr. Victoria will give us her conclusion and recommendations. And then finally, we will end with Dr. Jane. Dr. Sandra.
All right, thank you. I actually chuckled as well to the last comment Dr. Jane made. It does make sense. Of course, prevention is better than cure. You'd rather drink a cup of water to hydrate yourself than drink loads of alcohol and kill your liver. And you never know, like all the different consequences of some habits that we undertake, and we need to be responsible for whatever. Life is life. We need to enjoy life, but we need to be responsible, and we need to take charge of our actions. So I think Dr. Jane summed it all when it comes to screening. So we do encourage that our people become more aware of their health. I call out to the different community members to don't just wait to listen from healthcare workers and healthcare professionals about health and health events. You can also read about it if you have access to internet. You can Google any health information you want. If you think you're afraid to go talk to the doctor initially, you can go online and search for information until you gain enough confidence to address some of the sensitive issues that people think they cannot address with the doctor, etc. And I think the other thing, just two things. I really hope that eventually or soon our Minister of Health comes with the National Health Insurance Plan, and this is just to ensure equitable health service delivery to all those who deserve it, because we do have a big imbalance when it comes to health services access. We all know we lose a lot of lives, mothers and children in South Sudan, and then on the other hand, we also have individuals who travel abroad for the most minor health events. So we do hope and pray for equitable health distribution and equitable health services for the people of South Sudan. And last but not least, let people also not forget about dental and mental health. So in as much as you want to know about malaria and diabetes and hypertension and COVID-19, don't forget about your dentures, your teeth, your oral cavity is very, very important. It's good that we're seeing many dental clinics coming up in South Sudan, and we hope that we start adopting the culture of visiting the dentists for adults and for children. And mental health is very important. People continue to ignore mental health, anxiety, depression, psychosis. All these different conditions are real, and they affect people. And there's a large number of people who are stigmatized against talking about mental health, whether for themselves or for their family members and loved ones. So yes, stay safe and do seek health education and health awareness through the different channels that you can, and seek dental care and seek mental health care as well. Thank you.
Thank you so much, Dr. Sandra, for especially emphasizing on dental care. I think that's something that we have not sort of had an opportunity to talk about, and we hope we will. Dr. Benna would have been here to discuss the mental health issues, but we will arrange for another session for that, because it's actually very important, as you said. Dr. Victoria, but thank you so much for that overview and for encouraging people to actually look for information on health and in various avenues and seek the appropriate help when necessary. Dr. Victoria, your conclusion and
Yeah,
recommendation?
and I just want to thank Anne for giving us that overview and that elaborative conclusion, and also a discussion on non-communicable diseases. The Ministry of Health has worked on a package of service and strategy for non-communicable diseases. It was waiting final approval by senior management. Hopefully, it's one of the recommendations that the Ministry of Health need to complete and adopt and finalize the NCD strategy and package of service, which is very, very important. I also think that increasing the budget for health should be a priority for the Ministry of Health. Domestic funding is very, very important. At least it will also give us a bit of a, a bit of respect from the partners. We cannot keep pushing everything to our partners and to development partners. We need to start putting domestic resources for health and increase the national budget for health. It's also important to strengthen screening and surveillance, and improve the infrastructure, diagnostic services and scale up testing for COVID-19 and for other diseases as well. And it's important to improve our capacity and build capacity for COVID-19, and not forget that COVID-19 is not only the killer. We cannot neglect the other diseases in the country because of COVID-19. We have to live with the new normal of COVID and continue to push and not neglect the other disease programs in the ministry. All in all, we want the Ministry of Health to continue pushing and to continue strengthening the health system in the country. But again, with health professionals like yourself and Jane, who are in diaspora, your expertise is also needed. And if you are not here, we can always benefit from your expertise, from your skills, and from your input to improve the health system in the country. Thank you.
Thank you so much, Dr. Victoria, for reminding us that we need to be in our country also to make the difference and to give services to our people. And I think we are in the process of actually getting there and doing what we need to do. And even for those of us who are far, I'm sure there are ways that Dr. Jane, you have also contributed, even despite the fact that you're in the diaspora, and we will continue to try and lend a hand as much as we can, and if possible, even come there physically. I'd like to thank you for your sacrifice, Dr. Victoria. I know you left Australia to come and serve our people, and that is such a great thing that you have done. And yes, for emphasizing on domestic funding, we need to actually take control of the situation and find a way to make health work for our people by also coming up with great ideas like Dr. Sandra has talked about, the National Health Insurance Fund, and hopefully that with time that is a way that we can go. So Dr. Jane, your conclusion and recommendations.
Really, my conclusion is basically to the people. Usually, I am not a person that really likes recommendations to the Ministry of Health or things like that, because there's a lot of good-minded people over there. And if they can't listen to those people, they may not listen to mine. That's what I think. You have great women that just spoke here. They are doing marvelous over there. I'm a person who likes to do than just talk and say, hey, you do this and you do this. But what I think we can do together is that come up with the guidelines to help our people how we can deliver healthcare services in different settings. So in general hospitals, in specialty hospitals, in private clinics, and in even healthcare clinics, so that we can screen people across the board in all the 10 states the same, and we can provide services to them the same, not withholding services from other people. For example, as one of the speakers just mentioned, other people can go out of the country just for petty things, while a woman giving birth in a rural area cannot even have services. I have seen a video where a military personnel committed suicide because his wife was trying to give birth He could not transport his wife to the hospital. He went to his general to ask for transport. Galia Arabia de Kumdan Mashibo. So Mafia Arabia Zolda Bagdar Bishil, Askeri Bagdar Bishil Maratofi Mustashfa. And he is working for the government. He is a military defending the government. Lakin ma Bagdar beside Marato, ma Bagdar beside Yalto. This resulted into a suicide death because the man was in a very bad situation. So if our healthcare services was distributed evenly to all the locations and all those areas, that man could have still been a father out here to his kids. And if we can, as healthcare providers, doctors, nurses, all in South Sudan, work out a plan that we can even communicate on by emails, get on Zoom together, put in a policy that really works for us to help screen our people for these non-communicable diseases, we will be able to catch the communicable diseases when they show up while we are screening non-communicable diseases. And with the surveillance in place, we will be in a much better place than we are today, and we can move together and stronger and better. Again, somebody will say, what about the resources? I have heard about the challenges of resources. The doctors that just spoke today have talked about the challenges of the resources. That's where those on the ground can really make a huge impact of leading the way and saying, you know, this is where we found resources before, this organization finds this, and this is what our state can offer, and this is what our country can offer. How can we put this together and make it work for us? So what I'm emphasizing is that unity of the healthcare professionals, excuse me, unity of purpose for the healthcare professionals to do better for our state and for our people, to deliver service up to the end of the periphery so that every woman, every child, every man is not left out. The health insurance plan sounds good to me, but we have tried that before in Juba and it didn't work. It didn't take long to disappear. So I don't know how that new plan is coming out. I would like to hear more about that. And my gratitude to all of you. Thank you.
Thank you so much, Dr. Jane. I'd like you to note that despite the fact that we feel that sometimes we give recommendations and they're not followed, believe me, I'm sure somewhere someone is actually listening, and hopefully whatever information we've given out, whatever ideas that we've given out, it's going to have a ripple effect, in the sense that even if we do not see the impact right now, the people who are listening to you right now, who are going to be leaders in healthcare in South Sudan very soon, and I'm sure they will take your suggestions to heart and make a difference. So don't be discouraged. Definitely there's an impact to what we're doing and to some of the suggestions that are being given on this forum. And I like the fact that you have mentioned that we can use infectious disease surveillance programs to also help with screening for non-communicable diseases. And I think that's a very important recommendation. Thank you for that. So as we end this session today, I am so grateful to have you all on the panel. I am so proud of you as South Sudanese women in each and every place that you are right now, and in each contribution that you're making to both the society in the diaspora and in South Sudan. I am particularly very proud of Dr. Victoria and Dr. Ayak, and Dr. Sandra, who are currently on the ground impacting on the community there, and Dr. Jane for joining us and sharing her knowledge and her experience of the diaspora. On behalf of Dr. Ayak, I'd want to apologize for the issues with the internet. Hopefully with time, and if we're able to partner with other organizations, we will be able to provide internet for our panelists in other states, and hopefully this is something that will happen sooner rather than later. So I sincerely thank our panelists today and the audience for listening in, and Aisha and the technical team, and UN Women for providing internet connectivity for our panelists. And as we conclude, in view of the current COVID-19 pandemic and the rising cases in South Sudan, we would like, as healthcare professionals, to emphasize to all to practice hand hygiene, social distancing, and the wearing of masks. With this simple and yet effective public health intervention, we will be able to stay safe and keep those around us safe. We also encourage those who are affected or infected to reach out to health professionals and to isolate themselves to reduce the impact of spread. We also wish those who are unwell a quick recovery. Especially we'd like to remember Benna, who has not been able to join us, and Dr. Sandra for joining us despite the fact that she is unwell. And we wish you all a quick recovery. And we probably would take just a moment of silence for just a few seconds for those who have passed away during this pandemic. So I'll just take a few seconds. Thank you so much for those few seconds of respect and a remembrance of those who have passed away during this pandemic. And I would like to thank you again for joining us, the audience, and thank you for your participation. And please feel free to share this discussion with others who will benefit from what we have talked about here. Thank you so much, and welcome again for our next discussion that will take place at the same time on Saturday on our page, and we will be streaming live on different social media platforms. Thank you, and we'll see you again soon. Goodbye.
Thank you, everybody. Don't forget, it is a period of Lent now.
Thank you so